Hi, I'm Dr. Mark Studin, and today with ChiroSecure, we're going to bring you some basic information, which is really not basic. It's the core of what we do. And unfortunately, too many don't understand what it is we treat and what happens when we treat. It's the spinal lesion. I'm not going to say the chiropractic spinal lesion because that's absurd. It's a spinal lesion. Some people call it subluxation. I choose to call it biomechanical pathology, and we've talked about that in the past. But we're also going to talk about the chiropractic spinal adjustment. We don't call it a manipulation. There is a very big reason for that, and the evidence in the literature says that chiropractic spinal adjustment has over an 830% better outcome than people who manipulate. And that's what we're going to be discussing today, the core of it. So what we're going to do, let's go to the slides, and we're going to bring it up. Here we go. Oh, by the way, take your phone out if you want to contact me. There's my cell phone number, some other folks with things that we do, and QR codes. So you feel free to contact us at any time, or just give me a call. Now, this is the Discover Your Why in chiropractic. And I sat with a medical primary care provider about 6 or 7 years ago, and he wanted to know about chiropractic and why it worked. And I shared it with him, and he said, Dr. Studin, he called me Mark. He said, Mark, I've never heard that before. I heard this philosophy and pain, but you explained it, and now I understand it. He started referring 35 new cases a month to chiropractic instead of physical therapy because there was someone who could explain it to him in cogent scientific terms. And that's what today is about. But also, chiropractic is safe. According to Wheaton McKenzie Phillips in 2015, I ain't breaking new ground here, folks. It's old. With a cohort of 6,669,000 people, it was safe. There's no mechanism in which a chiropractic, the research called it spinal manipulation, is a chiropractic spinal adjustment, induces injury into normal, healthy tissue. And we'll talk about non-healthy versus healthy. So therefore, what we do is pretty safe. But we're looking at facets. Now, if we look at facets and we see what's going on here, this is an MRI in an axial view, the guillotine top-down shot that most people don't understand. But this is the facet joint right here. And actually, it's a T2 weighted image. Fluid is bright, so there's a little bit of white in here. This bright versus this side dark means there's inflammation in here. And I colorize it for you to show you where the facet is. We need to understand facets. And if you don't understand this image, to know that this is a lumbar spine because we have the cauda equina here. These are the neural canals. This is the ligamentum flava. If you don't understand this, you really have to. You are decades behind in understanding where your education needs to be. And give me a jingle, we'll talk about MRI education. So, but here, there's something in the facets. This is one bone, this is another bone. This is the cervical spine I'm looking at. A cervical spine meniscoid separates the facets. It's a separator. It's also a synovial fold. Some people call it a plica or intra-articular inclusion. And that is critically important to understand. There are folds of synovium that extend between the articular surface of the joints of the spine. So watch. Here's what it looks on an MRI. Here's a dorsal meniscoid and here's a ventral. This is the facet, okay? This is C1, C2, just in this particular image. Here it is in an MRI. You're looking at the dorsal meniscoid, the ventral meniscoid. So it's a spacer, it's a holder. So what happens is when the joint buckles, in other words, one side rides up and the other side rides down, that meniscoid retracts or folds, okay? And watch, when that happens, the facets approximate. Like cymbals, they approximate. This is your bone on nerve, folks, right here, because there are nociceptors on those facets. That's your bone on nerve. It's not the nerve root. I mean, that's been disproved, and by the way, it's not to denigrate BJ or D.D. Palmer. In 1895 or 1903, when they came out with the science of what was the Science of Chiropractic? I think that's the name of the volume of the Green Book. It was a brilliant finding. Consider all they had was X-ray, which was just invented in 1895. So It was a brilliant finding, and they were darn close. There is bone on nerve just at the facet level. And when that occurs, it releases substance P and calcium and CGRP. And that's really important. They're pain generators. All of that is pain generators. I'm not going to go through all of this, much too complicated, but it releases a whole bunch of stuff. Those are neurotransmitters. And what happens when you have those bone on nerves, you get cytokines, not just substance P and CPRG, you get cytokines and chemokines. Those are also pain generators and immune regulatory substances. A whole bunch of stuff. It causes inflammation. It causes pain. It causes a whole bunch of stuff. And that feeds into the lateral horn through the DRG, the dorsal root ganglion, into the lateral horn. But it doesn't just yet go up to the brain. Okay, it does go to the brain, but it does something first. But when it does, watch. You've got the nociceptors. And by the way, spoiler alert, I don't have that in this presentation. In the joint capsule, you have Pacinian corpuscles and Ruffini corpuscles, your stretch and crimp receptors, and your Golgi tendon apparatus. Those are all mechanoreceptors, which also feed into the lateral horn, all of them. So you've got stuff going on at the facet. You got stuff going on in the joint capsule, the Pacinian corpuscles, the Ruffini corpuscles, the dorsal root ganglion. Those are your mechanoreceptors. What's happening to my body from the outside in? They go up the spinal thalamic tract, through the periaqueductal gray area, into the brain's clearinghouse, the thalamus, hits the insula, anterior cingulate cortex, prefrontal cortex, orbital cortex, somatocortex, motor cortex, hypothalamus, etc. And then it goes efferently back down, off into disparate areas for biomechanical regulation to create homeostasis or plumb. I am not going to get into that right now. That's much too complicated for this conversation. So when you have that bone entrapment, okay, it's a ligament, by the way. The ligament is your joint capsule. So what happens is, well, here you go. Your Pacinian corpuscles are in your facets, okay, and the ligaments, which are your crimp receptors. Your Ruffini corpuscles are your stretch receptors, and your Golgi tendon apparatus. Folks, I'm not breaking new ground here. I shouldn't be losing you. You learned this all in chiropractic college in school. This was taught. I know it's still taught because I teach in the classroom in one chiropractic college, and I teach at a graduate level at another, and I know it's still taught in the classrooms. Those are your afferent nerves, your mechanos. But then, how does the body know how to change what's going on? And it does that through the deep paraspinal muscles. So what happens when your mechanoreceptors go into the spinal cord? Before it will, almost instantaneously, it shoots and it says what's going on in the deep paraspinal muscles. And it does that through, I'm looking for a slide. It does that actually through piezo ion channels. That's a communicator. There's something called the piezo ion channels, which feed out into the deep paraspinal muscles. These tell the body what's going on. They're reacting to what's going on the outside. This is what's reacting to this is what's going on in the inside, and that's called the proprioceptors. So the mechanoreceptors and the proprioceptors both then feed into the lateral horn and then go up combined, so the brain has an appropriate schema of what's going on in the body. Now, I'm not going to go through any of this stuff. And this is why CNS, you have central motor, central nervous system, you have central motor control, central segmental motor control. The brain is where all of this is happening. So the pain is not really localized. The pain is being sensed by the brain, and the brain's going to do a whole bunch of stuff with it. Listen, and it's all evidence-based. And again, we're not breaking new ground. 2019, 2011, 2021, it's relatively new. But here's the thing, folks. You're not going to learn all of this stuff in a soundbite. And what we're doing now is a soundbite. It's a soundbite. So we've got programs that explain all of these things in intimate detail that you can watch over and over again. That's in our primary spine care series. We've in September and October of 2026, we have our 19th one. You don't need the last 18 to understand 19. It's just the next level of research and what comes out and the latest and greatest and how to use all this stuff in real practice and actually how to put it in the real world in marketing. To actually increase your utilization, to get new patients, and to manage your patients. It is possibly the best education we have in our industry, and it's ongoing and it's live. It is recorded also. You can catch up anytime you want. We've retired 1 through 12 because it's outdated. We're now 13 through 18. 19th is being recorded shortly. But again, here I go. You've got the Golgi tendon apparatus, the Golgi tendon organs, and the ligaments. Then you have the piezo 2 ion channels from the deep paraspinal muscles, which go into the lateral horn. This is your safety pin, efferent and afferent, which then goes up to the brain, and it goes to different parts of the body, and it affects all of these things in the brain, folks. All of these things are affected because the brain has to be in a resting state, and it can't be when it's working to try to keep you biomechanically homeostatic. And it affects every single one. You know, it's funny. When I was practicing, after I would adjust a patient, I would say, I want you to look. The things seem clearer. The things sound sharper. I would say sometimes the things smell more distinct. And almost always people would say things seem clearer visually. And it blew me away, and I never understood why. Now I do. Because when the brain has to manage all of these biomechanical failures, it pulls, I'm not using the right word, but it pulls energy away from the brain or interconnections away from the brain to go do another function. And it lowers the brain function. When you normalize what's happening with the proprioceptors in the body and you get rid of the mechanoreceptor bombardment, now the brain can function higher on all the other things. And people see better. They think better emotionally. Everything, every single thing the brain does can work better. And this is, again, not breaking new ground. This is not breaking new ground. This is from research from 5 years ago. So we can go through what causes it. We can go all of that stuff. But here's really what you need to learn. Your mechanoreceptors, your outside forces, your car accidents, your sports injuries, your violent sneezes, your slip and falls, your repetitive micro traumas, all of these things cause the meniscoid to go out of place. Now, when you render a chiropractic spinal adjustment, which is going to be for a different conversation as well, you are separating those facets, which is why you need a high velocity, low amplitude thrust, not a manipulation. Don't be afraid to adjust your patient. Practice without fear. Don't be afraid to adjust your patient. It's a high velocity, low amplitude thrust that recedes that meniscoid, that separates the facets, that stops the nociceptors, that normalizes the stretch and crimp receptors, that tells the Golgi tendon apparatus you're no longer being overstretched, that stops the bombardment into the dorsal root ganglion, into the lateral horn, stops the piezo ion channels from feeding aberrant information to the deep paraspinal muscles. It stops the aberrant information going up the spinal thalamic tract through the periaqueductal gray area. Now the thalamus is getting normalized information, and it doesn't need to go to all of these disparate areas of the brain, lowering their function, and it doesn't need to go to disparate or different areas of the body to create things like mini curves in the wrong way to fix that 1 or 2 degree malposition based upon that meniscoid being out of place. The whole body works better, and only one thing in the world does that. You cannot have a pharmacological solution for a mechanical issue. Drugs can't fix it. You can't manipulate it. You can't joint mobilize it. You can't genie rub it. You can't shockwave it. You can't do all of these things because all of those things treat the effect. You know, we were in school, DC stood for 2 things, Doctor of Chiropractic and Doctor of Cause. We treat the cause, then the effect goes away. And there is only one thing on the planet Earth that could fix that, folks, a chiropractic spinal adjustment, which is why in a 2020 research article by Natadon, with a cohort of 8,033,000 patients, which is absurd in the high number of test subjects. 96% reported feeling and doing better with chiropractic care. What we do is wonderful. You need to celebrate who you are and share it. Folks, I want to thank you very, very much for spending a few minutes with me. I'm Dr. Mark Studin. If your camera's out, you can take a picture of this if you want any of these academics. If you want to learn anything, that's my cell phone number up there. I look so forward to working with you. Again, I'd like to thank ChiroSecure for giving me the platform to do this and share chiropractic. Sometimes you don't agree with me, and that's supposed to happen. We're supposed to have political discourse even within our profession. We're all not supposed to agree. That's what makes us better. But we do it holding hands moving forward as one profession. Thank you so much, and we'll see you next time.